My name is Iqbal Malik and I work at the Hammersmith Hospital. This is a case of atrial septal defect closure that I did this year, 2025. So the indication was an asymptomatic man picked up with a dilated right heart. We've done it under general anaesthesia with transoesophageal echo guidance. And here's a diagram of the borders of the atrial septal defect, which I'll show you on echo now. And so we deal with the anterior border, which is the aorta, and we'll deal with the superior and posterior border, which is also in that picture. And then we go around and try and measure on colour. Colour flow gives you a more accurate dimension. As you can see on this measurement, it comes to about 24 millimeters, but this is a three-dimensional structure, and so we do need all the boundaries. And this is X-plane, where we can see the anterior border, the posterior border, the superior border, and the inferior border all mapped out. We often do 3D as well. So how do we do the procedure? Well, ultrasound guided access of the groin. I usually do a long axis view, which is this, to map out what the vein looks like and where the hip joint is. And once I've actually done that, then I'll go to the short axis view, and the compressible structure is the vein. And therefore there should be no debate about when a needle is approaching the vein. And here's me dabbing the needle so I can get into it. And once I'm in with blood flowing going back into my syringe, then I can pass a wire into the vein and put a sheath in, a plastic tube. Once I've got the sheath in, then I can be deciding how I'm going to size. So one way of sizing, as we've discussed already, is in X-plane, where we can map out all the borders and get the two dimensions. And in this situation, we can see that we've got a 25 by 27 ASD. So the first way of sizing is to say, well, 20% larger than that average of 26, which will make it about a 30 millimeter device. However, the other way of doing it is to balloon size, and that's the way I usually do it. And so I've got a wire that's gone from that femoral vein all the way across into the left upper pulmonary vein, and then I'm going to exchange that to a stiffer wire, and through that stiffer wire I'm going to place a balloon. And once I've actually placed that balloon, then I can start inflating that balloon. You can see the wire across the atrial septal defect there, and then a balloon beginning to inflate. What I want to do is to see a clear rim on fluoroscopy and no colour going across the atrial septal defect, the so-called stop flow technique. And so as I inflate, I'm slowly moving the balloon back and forth and looking on colour to say, is the colour completely gone? And here you can see that no, there's still a little bit of colour which is coming through by the edge of the device, and therefore I have to inflate the balloon a tiny bit more. And once I've done that, put a few more mils in, then one can begin to see just the edge of a waist. And now there's much less colour flow seen, and on echo we can also do a measurement of the waist of the balloon. So we can measure again, and we can see what the margins might be, and this one becomes a slightly larger defect, and we can see this is about 35 millimeters, which would make it a 36 device that we would actually need. So you can see that there is a difference in sizing, but what the balloon doesn't do is to actually enlarge the defect. We're not putting high pressure in. So this is an Occlutech Figulla Device, 36 millimeters, gold, with a ball that we attach to the delivery cable. Of course, it goes through a large sheath. This is a 12 French sheath going up into the pulmonary vein on that same wire, and we withdraw the dilator. So once the dilator is withdrawn, then what we can do is to see the empty channel inside on echo. This is useful because that empty channel means that I don't have to irradiate my TOE operator or the anaesthetist or the patient or myself. I've put the loader on and I can see the gold device, the silver and the black, and then I'm going to slowly insert the device. So the gold goes in, the silver cable goes in until the black is in. And once I've done that, I detach the loader completely. It's got no purpose now. And now I'm going to try and de-air the system. Not everyone de-airs, but I think that there should be no air in the system. And because the pressure in the left atrium is high enough, a few drips come out, and when they're coming out, there's no more air coming out, then I'm comfortable that there's no air ahead of the device. And so then I push the device in, watching those tram lines on echo until I'm up at the top, and then I can switch to fluoroscopy, and you can see the left atrial disc just about to come out. And oh dear, this disc has not come out as a disc. That is a problem. And this is what's called the cobra effect. And the device has bent on itself and it's become mangled. So the question really is that recoverable in the body, or do we have to completely recapture the device and reshape it? Well, as I manipulated this device, the left atrial disc uncoiled itself. And so you can see it's a large left atrial disc on TOE. I'm now deploying the right atrial disc, the waste comes out. And the way to do that is withdraw the sheath while holding the cable sealed. And once I've done that, and you can see that happening now, on echo in particular, we then have to assess whether we've grabbed all margins of the device and whether the device looks in reasonable shape. Are the discs fairly flat? Have we got any edges that are in discomfort? And we also see whether it's stable, doing a push-pull. Now this device doesn't look quite as flat as some of the devices I've put in, and so the question is it too big? Is the cobra effect still there? And do I need to change? So we had a careful look at this, and also on fluoroscopy, and there's a real debate in my head about whether the fluoroscopy looks as good as I've often seen it, and also whether the echo looks as good as I've often seen it. It doesn't look quite the way a device should look yet. And if we look at echo, it looks a bit fatter than the device should actually look. Although it's caught all the margins, the left atrial disc is a bit bulgy, and there's still a bit of colour flow, although that can sometimes disappear when I release the cable. We need to look to see whether the posterior margin is caught, which is what we're trying to look at now, and look at all the other margins as well. So I'm scooting through the angles, and so this is about 100 degrees. The device is looking reasonably flat. There's no big colour going through, and in a minute we'll go to 120 degrees as well. But you can see the device, the left disc is just not looking quite right, and I'm still thinking, should I remove this device? What shall I do next? And in the end, the decision I made was that at this particular deployment, I'm not comfortable, even though there's not much color flow at the edge of the device. That color is going through the device, that there's nothing absolutely obstructing, but it just doesn't look quite right to me. So after looking all the way around, in the end I decided I was going to recapture and probably withdraw the device completely and maybe try one size down. And so we're looking at all the rims again in detail, but really thinking we might change up. So it looks reasonable, but could it look better? And so my next move was, having looked at the echo for a while, to say I'm probably going to recapture the right atrial disc and the left atrial disc, and maybe move to another device. Although again, you can see that the mitral valve is not being touched, it's splayed on the aorta, and all the margins at least have been caught. Just there's a line that just does not seem right to me, and I was wondering whether there was still a remaining little bit of cobra which I hadn't sorted out. So I've pulled the right atrial disc in, and you can see it's recapturing, and then I was about to pull the left atrial disc in, and then I suddenly thought, actually it's changed its shape slightly, and so is it worth just redeploying? So you can see when that shape change occurs, and so I'm just going to keep on playing, and just at that moment the left disc actually changes to a slightly different shape, and so I thought, well, let's have a look again. So I've redeployed it, and so now the left atrial disc looks a little flatter. It's still splayed around the aorta, and so that's absolutely no problem. It's away from the mitral valve still. You can see that there. And then I'm looking at the posterior margin, which is well caught. I don't think this device is going to move. And at 0 degrees, we've got the top and the bottom of the heart, and we're looking in better shape. The device just looks marginally better than it did previously. It's splayed on the aorta, and of course one has to make a decision about whether this looks good enough or whether actually I want to take it out, it's still on the cable, and put in a different device. But I felt that now that it looked actually pretty reasonable, and a smaller device might have a slightly larger chance of falling out. A larger device might have a slightly larger chance of erosion, but let me test the tug again. And so I'm pushing and I'm pulling fairly hard. This device does not seem to be moving, and so I became comfortable that the splay on the aorta that we have here is what was needed for a bald aorta, as it's known, and if I put a smaller device in, then it may end up actually poking the aorta a bit more and being more dangerous. I always take a PA shot because that's what a chest x-ray will look at. I've done an LAO shot to see that the disc was fairly reasonable now, and then we've done a set of views to make sure we're not actually impinging on any other cardiac structures. So splayed along the aorta, but not denting the aorta. As we go around, the coronary sinus is okay, the AV valves were okay, and the infra-posterior rim was caught with no leaks, and the anterior superior rim was caught with no leaks. So I think we've got a result here, and therefore I made the decision that I was going to release the device. And so I would say that in summary, we've got a successful atrial septal defect closure. I can tell you that 3 weeks later, the transthoracic echo looked excellent and the patient was doing well. I look forward to seeing you next time.